Good morning, everybody. First of all, on behalf of the Neurovascular and Stroke Unit, Department of Neuromedicine, I again welcome you all in this workshop. This workshop is meant for learning neurointervention in acute ischemic stroke. Now, my topic is a little bit different. I am a non-interventionist and my focus will be on intervention at society level, at the level of administration, and at the level of other medical professionals. Now, you may ask me, what's the importance of this topic? The simple reason is stroke is a very common condition, one of the leading causes of mortality and morbidity, we all know. And the other important factor is that it is a very time-sensitive management. We lose 1 minute means we lose 1.9 million neurons in the brain. Now, when you try to develop any new service, whatever specialty it may be, there is always some challenges, some barriers, some resistance. Resistance may come from within you, within your department, within your colleagues. Resistance may come from society. Resistance may come from administrative level. But at the end, if you are convinced that the service which you want to start will really be beneficial for the society at large, you have to overcome all these challenges, like challenges at the level of awareness, access to stroke-ready hospital, proper triage of the acute stroke patients, develop a dedicated stroke unit, manpower development, and today's topic, Cath lab and intervention unit development. And only if you can ensure these three components, that is care of acute stroke patients, if you have a research aptitude, and if you can somehow influence the public health policy, then only you can implement what you intend to do. So first start with the stroke awareness part. This is one of the most important and challenging part. Because when we are talking of neurointervention, we are always telling the patient must come within the golden period. Now, this is possible only if we can generate adequate awareness in the society. Both stroke and MI are acute vascular events. But the difference is that in stroke, the symptoms are very varied, contrary to acute myocardial infarction. And the investigation facility like CT scan is not available everywhere, and there is no reliable biomarker of acute ischemic stroke till date. And when you manage a stroke patient, the diagnosis must be very accurate. At the same time, you have to take a very rapid decision. If these two things are considered, they may seem contradictory, accuracy and speed. But if the treating doctor properly utilizes the clinical information what he is getting, and if he has a good idea about interpretation of the available neuroimaging, then only it will be possible for him to balance the two. That is accuracy and speed. And this is the slogan, be fast. We are using everywhere at community level. Right now, in all the blocks, subdivisions, villages of West Bengal, we have distributed this leaflet containing Be Fast so that each person in the society becomes aware of the symptoms of acute stroke. We are repeatedly telling people that if you have any of these symptoms in isolation or in combination, you always suspect that you may have acute stroke and you immediately report to your doctor. Now, as clinician, it is our duty to make sure that this information reaches to the community level so that the community at large becomes aware about the early diagnosis of stroke. We have now a ICMR sponsored project, TestNet, where we have selected 9 hospitals in West Bengal, and the 9 hospitals are divided in 3 arms. In arm A, there is telestroke program as well as intensive community level campaigning about early identification of acute stroke. In arm B, only telestroke service is available, but no intensive campaigning is being done. In arm 3, there is no telestroke service at all and no campaigning is being done. Our hypothesis is that at the end of 3 years, most likely the arm A, where intensive campaigning is being done for early identification of stroke symptom using the Be Fast mnemonic, in those groups we will get greater number of patients in golden period. I cannot disclose the results of this study right now because this study is yet to be completed, but I can tell you till now the trend is like that at least 80 to 90% in arm A, they are reaching the hospital within the golden period. I am trying to tell this thing because unless you sensitize the community about early identification of stroke, you cannot ensure proper or quality management of stroke at all. Next important issue is access to stroke-ready hospital. Now, what is a stroke-ready hospital? A stroke-ready hospital is one where CT scan facility is available 24/7, where in the emergency there are doctors who can recognize stroke symptom, who can interpret the CT scan and identify the type of stroke, who can thrombolize the patient, and who can manage if there is any complication following thrombolysis. These hospitals are called stroke-ready hospital. In our state, at government level, we have 41 stroke-ready hospital. Now, once they reach the stroke-ready hospital, another important issue is the triaging of the patient. Now, before that, triaging you may have to do at the community level. At the community level, what we are telling, what I have just told now, once you suspect brain stroke, you always go to the stroke-ready hospital, not to any hospital which is not stroke-ready. And the treatment, you get treatment there, and I have already told what you mean by stroke-ready hospital, and then appropriate treatment is given, that the patient is discharged. So, we are trying to convince people so that come within the golden period, that is 4.5 hours, he issues a green slip to the family members. With that green slip, the patient is directly sent to the CT scan room, where the CT technician gives maximum priority to the patient so that the CT is done as early as possible. Once the CT scan is done, then it is uploaded in the telestroke or Sastro Sati portal, and the doctor in the hub, he can look at the CT, and sometimes if the physician in the emergency, he is competent enough to interpret the CT, he can also look at the CT. Now, if it is a patient eligible for thrombolysis, then the thrombolysis procedure is done either in the emergency itself or in the nearby medicine ward. So by issuing this green slip, a significant amount of time can be saved and appropriate management can be ensured within this golden period. Another important challenge is to develop dedicated stroke unit. Now, we all are aware already in an ICMR project, we have found that implementation of phase protocol, that is management of fever, high sugar, swallowing dysfunction, and hypertension. These are the 4 important components. If you can address properly in acute stroke, you can achieve a good outcome. Now, this implementation, though we teach in classes, but in actual scenario, this is a rarity, at least in government sector all over the country. And deperfusion therapy is mostly unavailable due to various barriers and inertia among health professionals. So our first goal was to develop a dedicated stroke unit where protocol-based treatment can be offered by a dedicated stroke team, and we can accommodate higher number of stroke patients and also increase the availability of deperfusion therapy. With that goal, in our institute, we have developed hyperacute stroke unit where acute stroke patients, those who have developed stroke within last 24 hours, are admitted. In hyperacute stroke unit, the important service that we offer is proper assessment of the patient, including severity assessment by NIHS score, imaging by imaging aspect score, functional assessment. Next, the patients are given IV thrombolysis or mechanical thrombectomy or intracerebral aneurysmic coiling in appropriate situations. And the other part is implementation of the phase protocol and early rehab. These are the important components of service in hyperacute stroke unit. And the benefits that we get, there is a sharp fall in mortality. In general ward, the mortality is around 14%, while in last 3 years, in HASU unit, the mortality is around 7%. Number of deperfusion therapies have increased, and above all, we can accommodate more number of patients, acute stroke patients. After 3 to 5 days, these patients are shifted to the emergency ward, where we try to manage post-stroke complications. We ensure proper rehabilitation and also follow the protocol-based management which was already initiated in hyperacute stroke unit. And the whole team consists of neuromedicine people, medicine people, neurosurgeons, radiologists, nurses, physiotherapists, occupational therapists. There is dearth of speech therapists, but on emergency basis or SOS basis, sometimes speech therapy is helpful. And once the patient is discharged, we follow up these patients in a dedicated stroke OPD, which is held once every week, where the follow-up of the patient is done and there is provision of physiotherapy, including group physiotherapy. So the flow of work is, first patient is admitted in hyperacute stroke unit, then they are shifted to emergency neurology ward, and they are further stepped down to another ward for subsequent management. And subsequently they are followed up in the OPD. Now, to do this, another important challenge is development of manpower. We have to develop manpower in terms of empowerment of the faculties and fellows and trainees, and the faculties in this stroke service include stroke neurologists, senior neurointerventionists, postdoctoral trained senior residents. And the trainees are our students, postdoctoral students who are pursuing their DM neuromedicine or MC neurosurgery courses or MD radiology courses. And all these trainees have adequate access to these intervention procedures. As well as we have to train other manpowers like nursing staff, radiology technologists, and non-medical manpower. The last part is development of Cath lab and neurointervention team. And you all know that this is a procedure, this is one of the most recent advances and which can save a lot of patients in terms of mortality and morbidity as well. But in a resource poor country like us, there are a lot of barriers to develop a proper neurointerventional Cath lab, like lack of equipment, trained manpower, lack of awareness, and in some of the procedures, the cost is very high. The Cath lab facilities should be good. Biplenar is always preferable, but it is costlier. You should have image backup facility and availability of emergency drugs. And the good Cath lab team consists of, apart from interventionists, should have good technologists, Cath lab trained nurses, expert anesthetists, and experienced non-medical staff. And the training program of the people involved in Cath lab should go continuously and on regular basis. And the instrument and devices that you use should always be of good quality. I'm not going to do this. So the take-home message is that this is a rapidly progressive field, but if you are determined to go ahead with this service, you have to know its strength, its weakness, and you have to discuss at all levels so that you can carry it forward. Thank you.